And what is the indication, contraindication of such block, and what methodology used for this hypogastric block, and what is the limitation. This is the main aim of our topic. Firstly, what is the history of this hypogastric block? In 1921, Lyrics, he applied periarterial sympathectomy for the dysmenorrheic, and lastly name is given by this Lyrics as a pelvic neuralgia due to the pain severe due to the dysmenorrheic pain due to the sympathetic innervation of this nerve. And after that first interventional approach by the Penacurti and his colleague in 1999, and he successful blocked the superior hypogastric plexus by posterior approach with the use of UAG fluoroscopy. And in this technique, he targeting the anterior border portion of the L5 vertebrae, and this time he used the 2 needles for procedure. Thereafter, he that time has also used the single technique, and lastly, he is also applied for the posterior transdiscal approach, and this is the most successful done by the fluoroscopy guided. After the fluoroscopy, CT guided by the Waltman and Wilson, he is also but is most costly procedure lastly emperor. And thereafter, Kanaji and Fredericks, he apply also a fluoroscopy guided through interior approach. After that, the most evolving in our UAG guided by the Seema Mishra and S. Bhatnagar, Madam of Delhi AIIMS, is also professor in Cancer Institute of AIIMS Delhi, and he first successful published a paper interior UAG as a interior UAG guided superior hypogastric block in 2008 in anesthesia intensive care, and this is the most evolutionary, especially UAG guided. Thereafter, this group is also applied for the advanced gynecological procedure for similar block, and lastly published in 2013. This is the main evolutionary science for the UAG guided in the field of superior hypogastric block. When we compare from the CT scan, a comparison study in 2016, Kamil and Ahmed group, and compare both UAG guided as well as UAG CT fluoroscopy guided, and compare by those groups before the pain 7.9 and UAG guided 7.6. Post-operative, post-procedure day by both group, we compare 3.4 and 3. First, we see the UAG guided is more important comparison to the CT scan guided. As well as we see the main morphine requirement after the both group, as we see the UAG guided require much less than the CT scan. That is easy to UAG guided posture is more beneficial, especially for superior hypogastric blocks. Thereafter, we want to know what is the anatomy and of the superior hypogastric block. The main is this is retroperitoneal midline structure formed by the upper lumbar and lower thoracic of the sympathetic chain, along with the aortic plexus, lies situated on the L4-S1 vertebrae anterior to the bifurcation of the abdominal aorta. This is the main site of the hypogastric nerve. Lies intermedial to the psoas muscle and caudal to bifurcation of the iliac vessels, and generally located lateral to this structure ureter to proximate to the L5 vertebra. This is the hypogastric nerve trunk, which consists of both parasympathetic as well as sympathetic. Parasympathetic branch arise from the S1, S2, S3, S4 as a nerve indentation and travels from the inferior hypogastric to the superior hypogastric plexus. And sympathetic trunk arises from the upper trunk, lumbar and lower thoracic, and mainly lies at the level of L5-S1 vertebra. Then, what is the structure that innervate mainly bladder, ureter, vagina, prostate, and rectum? This is the main structure innervated by the superior hypogastric nerve. Thereafter, we have also discussed the inferior hypogastric plexus, which is less important for the pain specialty, but its structure is extraperitoneal, not intraperitoneal. Occupy at the level of S4, S5 vertebra, lies between the rectum, between the posterior lateral to the pelvic viscera and the rectum. It receives branches from hypogastric from the pelvic, especially S2 to S4. Give rise to the pelvic plexus viscera. Just below the bladder neck or posterior to the prostate as a prostatic plexus and vesical plexus. This is the location of the inferior hypogastric plexus. This is the both hypogastric and the superior as well as inferior hypogastric plexus in a same. And this is a structurally draw picture of the different vesicles plexus. Then what is the indication? Indication mainly both malignant, non-malignant as well as malignant condition. Like in non-malignant condition, inflammatory condition, endometriosis, adhesion, chronic frozen pelvis. This is the main indication. Non-gynecological patient, interstitial cystitis, irritable bowel disease, chronic pain after the surgery like suprapubic, and patient with the neoplastic of the pelvic viscera, such as ureter, bladder, prostate, and others viscera, pelvic viscera. Indication of inferior hypogastric plexus mainly supplied by this plexus, mainly rectum and the bladder, penile pain, prostatitis, vagina, rectum and anal pain. Sometimes irritation induced tetanus is also a very important pain, which elevated by the pain inferior hypogastric block. This block is not commonly used, but we apply generally superior hypogastric block. Contraindication, infection, coagulopathy, distortion of common or complicated anatomy, and lastly patient refusal is the more important. This is the preparation of this patient. NPO at least 4 to 8 hour. Bowel preparation mainly prepare due to the obstruction. Anatomy is disturbed by the bowel. So bowel preparation important. IV cannulation position and probe choose according to the patient have patient condition, such as suppose patient is obese, so we prefer curvilinear probe. Patient is thin, lean and thin, flat probe. A step preparation of the patient in perioperative, always urinate the patient because bladder sometimes distended and distort the anatomy of the pathway. Always give antibiotic perioperatively 1 hour before the procedure. IV cannulation must be inserted before the procedure and shift the patient inside the OT. Now we have different steps for scanning of the patient. Scanning patient should be supine, and scanning always start below the umbilicus to identify the abdominal aorta, and lastly always trace down to the division of abdominal aorta. It is second method, we identify by the fifth vertebra by transverse probe. It may be it generally flat when curvilinear or convex of the image. It indicates the L5 vertebra or L5S1 disc. Generally use needle 15 centimeter 25 gauge Chiba needle for the plane. It depends upon the experience by the convenient to the pain physician, maybe inline plane or outline plane, depend upon the choice. And lastly, we target the lumbar body of the lumbar vertebra, fifth lumbar vertebra. This is the start from this, and we target the fifth lumbar vertebra. And this is the color Doppler flow of the both common iliac artery, and this is the when we hit the fifth lumbar vertebra, withdrawal 1 or 2 mm up from after the hitting the vertebral body, confirm negative aspiration, and drug use depending upon the, always use 8 to 10 ml of 0.25 for the diagnostic block. If the diagnostic block is successful, then we therapeutic by neolysis or other drug depend upon the drug availability of the, and real-time ultrasound show the flow of the, this is the drug flow and clouding above the needle. And last, what is the advantage of this procedure? Because it decreases the oral medication, especially morphine or thus drug dependent, and it is easily performed with minimum discomfort to the patient, and perform in supine position, less time consuming, such as in lateral position or other position used by the posture. And it is in this posture we always avoid the radiation exposure with this posture. And what is the limitation? Limitation is a relative low compliance, vessels injury, chances of vessel injury, more intravascular drug. So rarely may ureter injury due to the proximity of the to the ureter. So that generally we try to limit this procedure. Inferior hypogastric block rarely used in this day, but some physicians always try to block. And as we discussed, this is the extra peritoneal structure or just above the piriform muscle. So in this posture, always locate the piriformis muscle. So in this position, so hence this method always used for the to locate the piriform muscle for the successful block of this inferior hypogastry. And first successful block done by the and published by the Ahmad and his group as a in 2019 by transpyloric technique or this product for the pelvic pain. And technique used in this case is similar for the superior hypogastric. Perioperative patient should be always in should be given IV block or perioperative antibiotic also be use universal precaution also be done in this procedure. Use always in this procedure is a curvilinear probe. Use in this method or forefinger just lateral to the gluteal cleft to identify the piriformis. And slide caudally and rock medially to identify the vessels or cilia just along the rectal rectum. This is the hyperechoic surface. And lastly, tip advance to this passage, deep to the piriformis muscle, lateral to the rectum in plane technique. Careful after the aspiration, negative electrical stimulation may be done if we try to avoid the vital structure along this nerve, and 15 to 20 ml given in that side because this technique is given bilaterally. And this is the in the lateral position. Patient in lateral position. This is the gluteal cleft and forefinger that you try and rotate this. This is the hyperechoic region. Limitation because this patient all patient is this patient belongs to very limited position and very inconvenient to particular lateral position. So this block is very rarely used for the cancer or debilitating patient. As given bilaterally, drug or diagnostic block may be given first, then we neurolytic drug after this procedure, and more chances of the rectum because they are very close to the rectum. So this block is generally avoided for the block. And
thank you, sir. Thank you so much, sir, for the elaborative anatomy discussion of superior hypogastric plexus as well as the inferior hypogastric plexus. Thank you so much. And next, I will go towards our next speaker, who is Dr. Sudhakaran. Dr. Sudhakaran is an accomplished pain practitioner for the past 10 years. He is a postgraduate from PGI Chandigarh and PDCC in pain management from Institute of Medical Science, BHU. He is working as an associate professor at Karpagam Faculty of Medical Science and Research Center. And he is also a consultant pain physician at Dr. Murthu's Ortho Super Speciality Center and Erode Cancer Center, Tamil Nadu. Welcome, Dr. Sudhakaran. Could you please present your lecture, sir?
Thank you, Manish, for a nice input. I'd like to thank the ISPC members for giving me this opportunity. Okay. Today's topic is the intrathecal neurolysis. Good morning, everybody. From Coimbatore on behalf of Kapam Faculty of Medical Sciences and Research. and from Europe Cancer Center and Muthu's Hospital. The contents in the session, I am going to present a small intro about the intrathecal neurolysis with intrathecally, a small sample case history with relevant clinical anatomy and the technique, and neurolysis with phenol using saddle block method. So this intrathecal neurolysis, it dates back to 1931. And nearing a century, with the advancement of this pharmacological and scientific for better pain management, the use of intrathecal neurolysis has drastically reduced. However, in this current scenario, there are a few subset of patients, like patients with carcinoma of lung, carcinoma of breast, and carcinoma of pelvis with very near those who have short life expectancy, like say, books indicated like less than 6 months to 1 year, so preferably less than 3 months, and whose oral conventional therapy has failed because of the side effects or not able to follow. These are the subset of populations who are indications for intrathecal neurolysis. The main advantage with this technique is it is definitely cost effective, and it is like more of a daycare procedure. The follow needed and the resource needed is very less. If the good pain relief with achieved, then the opioid usage would be decreased, and thereby the side effects and increase the patient comfort. However, it doesn't come with disadvantages. Since it is a neurolytic procedure, there is always possibility of water weakness of the lower limbs and bladder bowel dysfunction, though a bit rare. And another thing is inadequate pain relief is a problem because this intrathecal neurolysis is going to target only somatic pain. The visceral pain and this neuropathic pain has to be taken care of with other procedures or with other medications. A sample case history was a 68 female patient with a history of CA breast with unfavorable prognosis. So she was referred to our pain clinic. She presented with a pain score of 10 by 10. The pain was mainly over the anterior chest wall, covering the dermatomes T1 to T4, and the pain was also present over the axilla. So since her prognosis is a bit unfavorable with a short lifetime expectancy, she was given the option of intrathecal alcohol neurolysis. She was done at the T2, T3 level at a 0.6 ml, 100% alcohol was injected. With this, she got very good pain relief till she died. So alcohol. The alcohol is a commonly used in neurolytic agent. However, it relieves pain by destroying the nerves non-selectively. It is non-selective. So it won't prefer for sensory or a beta delta fibers or small fibers. So however, what we want in this intrathecal neurolysis is only pain relief without losing the motor power. So what we want is selective sensory neurolysis. So our target is here the dorsal sensory rootlets. So how to achieve it? This intrathecally, that alcohol has a specific gravity of 0.7 compared to CSF more than 1 is hypobaric, so it floats. When it is injected intrathecally with pushing, we will be able to achieve the target site of dorsal sensory rootlets, thereby inhibiting or destroying the afferent pain impulse, reducing pain. Once good pain relief is achieved, it will usually last for 3 to 6 months. That is the usual time for regeneration of the nerve fibers. Once this preparation of the patient with the pros and cons of this procedure is discussed with the patient and make sure there are no contraindications for this neuroaxial procedure. One thing is bleeding and coagulopathy, the possibility of causing hematoma and causing weakness. And the other thing is any tumors invading into the spinal cord is definitely a contraindication. You have to raise the pros of, because that will affect the spread of drug within the CSF. We do not want the drug to spread into the midbrain brainstem, causing the patient to lose his respirability or down towards the lumbar roots, causing weakness or paralysis. Once this consent and this weakness is okay, then the dermatome should be assessed to chart out the plan, the level, because there is mismatch between the spinal cord segment and the vertebral bodies. What we want is, we want the needle to be placed at the origin of the corresponding spinal nerve, that is dermatomes, exiting from the spinal cord, not at the intervertebral foramen exit. Remember, there is a mismatch. We have to take this into account, and the needle should be placed at the appropriate vertebral levels. So technique, after the patient is ready and inside the operating theatre with IV flow, with IV canal underflow, antibiotic given, because it is a intrathecal procedure, the possibility of meningitis is always there. So subtraction 2 gram IV, and then with basic live monitoring, the patient should be placed in the lateral position. Painful side, it's because the alcohol is hypobaric, it floats. The patient positioning, these patients will be fragile, difficult for them to position themselves for at least for half an hour to 1 hour. So you have to support them comfortably with pillows and restrain them. Once this is done, under aseptic precautions, like standard procedure for intrathecal access, use a 23 gauge spinal needle. Too small a needle, it is difficult for us to visualize the free flow of CSF. So with the 23 gauge needle, once the free flow is confirmed, position the patient at 45-degree tilt towards the face and restrain them. Because once with this positioning, the topmost part would be the dorsal sensory nucleus, and whatever the alcohol we are giving will act at this place. So this 45-degree tilt you can achieve manually, or if you have a table that is able to tilt 45 degrees, you can do it with that. This 100% alcohol, usually alcohol near the nerve is very painful. So it is always better to add a locus. However, within the CSF, it is not so much painful because it spreads very rapidly. Please inform the patient mild burning sensation and remove. So 100% alcohol, 0.1 ml every 1 minute, feedback about the pain relief. If practically possible, try to check the dermatomes pain relief also. The maximum amount that without complications like spreading to the motor processes, like we want the target of 3 to 4 dermatomes only, not spreading high above or very low. So the maximum amount you can utilize is 0.6 to 1 ml. Depends on the patient's feedback. And make sure, and also it is possible that if the pain recurs, you can always repeat this procedure after a gap of 1 or 2 weeks. So once this procedure is over, the needle should be pressed with local anesthetic or saline to prevent uninterrupted spread of this alcohol to other nerve roots. So the possibility of neuritis and skin irritation should be there. So please splash with it. So a small rush taken into the OT with the monitoring attached and everything kept ready. Alcohol, subsolute alcohol. The patient position, you can use an IV stand to make them appropriate angle. Now the dermatomes. Once everything is ready, inject very slowly, gently, 0.1 ml every minute with patient feedback. Make sure you get the patient feedback and also look for the vitals. So how is the relief? So since it is this case are done over a century, there is not so much standardization about the volume, about the concentration by different authors. However, in a case series of about total of 5,000 patients, 60% patients got very good relief, and 22% got moderate relief. Around 10 to 20% there is no relief at all, maybe because of the other type of pain. So next, coming to the next is the saddle phenol neurolysis. Our sample case is a 34-year-old female patient, a mother of 2 children, diagnosed as having Ewing sarcoma sacrum. After chemotherapy with the unfavorable prognosis, she was referred for palliation with a last of 10 days. In EMR findings, her tumor has infiltrated the sacrum and the mass was extending to the perineum with severe pain, limiting her mobility. Initially, when there is possibility of prolonging life is there, she was offered local anesthetic plus opioid mixture through canal epidural. After that, because of the tumor advancement, the bladder and bowel were involved, so she was given saddle phenol neurolysis, and that gave her good relief till she was alive. This saddle phenol neurolysis, saddle block blocks or targets only the lower sacral nerves. The dermatomes covered while sitting in a saddle of the horseback, like inner part of the thigh buttock and perineal area. Phenol is another commonly used neurotic agent which causes protein coagulation and destroys action, providing pain relief. This mixture, however, aqueous phenol is we can't limit the spread. However, phenol with the glycerol mixture, it is hyper viscous, so it would be very limited to the target area. And this phenol with glycerol mixture is also hyperbaric to CSF. That makes the ideal agent for saddle block with phenol neurolysis. From the previous studies, it was known that phenol concentration less than 5% only causes the sensory blockade without motor blockade. And unlike alcohol, this has some affinity towards the small fibers, so it has intrinsic local anesthetic effect. So there is no need to inject local anesthetic before this itself. It has local anesthetic effect. However, the disadvantage means compared to alcohol is this: it is shorter acting, probably for 1 month to 1.5 months. Then we have to repeat the procedure. Technique: after proper patient selectance with the explanation there is possibility of bladder and motor paresis, the patient should be placed in the sitting position with vital monitorings and the intravenous fluid on the floor. These patients should be mostly of fragile or debilitated. There is within the sitting position there is always high chance of hypotension with bradycardia. So keep everything ready. So do it ideally in a OT setup with anti-aseptic precautions like saddle blockade for spinal. The lowest possible intrathecal space, usually L5S1, is reached with 20 gauge twin piece needle, or can use an 20 gauge epidural 2 gauge needle. So it has marking, it will give you better idea about the depth. And also if the patient movement, you can be able to adjust check the free flow of the CSF. Once the intrathecal space is reached, you can turn the needle so that no nerve roots are entangled in the tips. So we do not want to injure the nerve roots, or we do not want the drug to get deposited so concentratedly in the nerve roots. So once the free flow is confirmed, use this 5% phenol glycerol mixture in 0.1 number per minute increments after confirming the free flow of CSF. And also ask the patient feedback. Tell the patient you will feel some burning sensation in the perianal area or around the buttock region. So it depends on you decide the volume from 0.3 to 0.6 ml to 1 ml. The volume is decided upon by the patient feedback. Do it slowly and gently. But do not push, because this small, with the small gentle push, the drug usually settles down without going inside. That means not reaching the anterior, mostly it will settle down in the dorsal part. The patient should be seated in the sitting position for 15 minutes to 30 minutes to the drug to settle and act. A few authors recommend inclining the patient dorsally 45 degree so that the drug, only the dorsal roots like S2 to S4 are affected without affecting the ventral roots, so that the bladder and the motor pulses, the possibility is less. In patients like gynecological cancer, the spread of a tumor is more towards a single side, engaging the sacral plexus and that bone around it. In that type of patients, you can tilt the patient unilaterally, like 45 degree to the same side, so the drug will settle, and only that unilaterally the drug acts and gives pain relief. The main advantage of the phenol glycerol mixture is the phenol dissolved in glycerol becomes more, so because of the viscosity, it is more localized, and the drug, the phenol spread from that glycerol slowly. So in review, around in a 12 case series, 58% of patients got very good relief. However, 1/4 of the patients didn't get adequate relief. The most dreaded complication is the possibility of bladder and the rectal disturbances. So ideal patients should be who has already involved bladder and bowel. If not possible, otherwise try to limit the drug concentration on the volume. There is possibility of lower limb motor paresis, possibilities there. But the good thing is, even with this minimal of complications, most patients recover within 2 weeks to 3 weeks. That is a very good thing. And then there's always possibility of meningitis, as these patients are immunocompromised after radio chemotherapy and they will be fragile. And since we are using bigger needle, the chances of PDPH is also high. So summary, finally, in a carefully selected patients, the drug with the minute detail to the drug concentration and the volume and the proper positioning is definitely a tool for patients with advanced terminal cancer pain. I'd like to thank and acknowledge Dr. Professor R.P.S. Gedu and Dr. Ashok Kumar for sharing their experience about the intrathecal neurolisis. Thank you very much, sir.
Thank you so much, Dr. Sudhakaran. I guess many of us might have many doubts about intrathecal neurolysis because it's not that commonly done. And we will share, definitely ask for what all your experience you have in that. Before that, let us have our third speaker, Dr. Manish Kumar Singh. He's a trained practitioner, accomplished trained practitioners of Lucknow, a postgraduate from GSVM Kanpur, and he's done his PDCC from SGPGI Lucknow. Presently, he is working as an assistant professor in the Department of Anesthesia and Pain Medicine at King George Medical University. I welcome Dr. Manish Singh. Could you please start your presentation, sir? Dr. Manish is not audible. Just to unmute.
Thank you, Amitesh. Good morning to all of you. And thank you, Dr. Anurag, sir, Dr. Sarita ma'am, for giving me opportunity to talk in this important topic of pain management in metastatic bone disease. As you all know, we oftenly got patients in our OPDs with terminal cancers. And in solid cancers, they come up to our clinic with some mets in them. So, because in the solid cancers, patients with advanced cancers are prone to bone metastasis. And the most common cancers which lead to bone metastasis are solid cancers of lung, breast, prostate, and ovaries. So, in breast cancer, it has been diagnosed in 75 to 80% of advanced breast cancers. And skeleton is the primary metastatic target organ in more than half of the cases. So we have to focus on osseous metastasis, okay? Because they are very difficult to treat. Sometimes we doesn't find any answers by giving all the medications. Wishes to intervention, we will continue to morphine or bisphosphonates. So I will try to give some answers in this topic. So spine, pelvis, ribs are often the earliest sites of this metastasis. And most of the bone metastasis are found in the axial skeleton because of the predilection to the bone marrow. So what are the mechanism of bone pain in bone metastasis? So they damage the neurons. As the tumor grows or as the metastasis grow, they causes excessive stretch, excessive mechanical stimulation and inflammation, causes stretching of the nerves. They release tumor-derived factors such as tumor necrosis factors, endothelins, growth factors that stimulate the nociceptors. Apart from these, acidosis produced by the osteoclast also stimulate the nociceptors, and nerve destruction caused by the increasing size of the tumor. So basically there are two mechanisms. First, destruction or stimulation of the neurons, and activation or stimulation of the nociceptors. So what are the goal of treatment for the bone metastasis? As a pain clinician, our primary motto is to relieve the pain, because patient come in withering pain and no one has any answer to relieve this pain. Second, for bone metastasis patients, we have to treat the fractures, reduce the risk of fractures, or prevent or delay any bony complications such as spinal cord compression or hypercalcemia. But we are focusing here on relieving the pain of the patient. So what are the treatment strategies available to treat the metastatic bone disease pain? So as you all know, we start with WHO pain ladder. We start with systemic analgesics using non-opioids, then weaker opioids, then stronger opioids. So we can use them in ladder pattern. After then, we have, if the bone is involvement is widespread, we can use bisphosphonates, isotopes, denosumab, etc. For isolated bone metastasis, we can use local fear irradiation or interventional vertebroplasty. Or by ameliorating the disease, we can also control the disease and the pain. So anti-neoplastic treatment is helpful if it is possible. So before starting any treatment, the patient should be informed of the possible causes of their pain. So patient should be informed of various possible causes of their pain, the different therapies that could alleviate the pain, and furthermore, they should be encouraged to have active role in their therapy. So this is the WHO pain relief ladder we have to follow, and we follow in cancer pain management. The first is acetaminophen. As you all know, acetaminophen is effective in mild cancer pain, and they can be used along with opioids in moderate to severe cancer pain, and dosage is up to 3 to 4 grams per day. So we use acetaminophen in mild cancer pain. Dosage is, I have gone through some systematic meta-analysis, and I found that there is no evidence that taking paracetamol together with morphine-like drug was better than morphine, and paracetamol did not appear to improve the quality of life. Although we are using at first-line drug in mild pain, but Cochrane database review, systematic review in 2017 has given that there is no evidence. But we follow in our OPDs, we give patients paracetamol. But this is the evidence which came out in 2017. So there is constant rejigging of WHO ladder. So what should be the primary treatment of the cancer pain? So this has come for paracetamol. Although we use paracetamol in our OPD for mild and severe cases along with opioids. But this is the evidence. For NSAIDs, most of the studies for the NSAIDs in cancer pain or bone pain have been for short duration. And the use of NSAIDs analgesics is only for short duration and cannot be extrapolated for long-term use. And their side effects are also studied only for short duration, and they cannot be extrapolated for long-term use. And it has been found that no any NSAID is superior than other. So for NSAIDs, it is that it can be used only for shorter duration of time because there are no studies for long-term pain relief in cancer patients and the side effects of the NSAIDs. This is for paracetamol and NSAIDs. Coming to the opioids, it is the primary stay of treatment in cancer pain. It is the most effective and widely used drugs in the pain, used in moderate to severe cancer-related pain. Opioid drug produce long-lasting effect, and it is used in more than 80% of the patients of the cancer, and it improves and control pain and improve the quality of the life of patients. We use mild opioids, strong opioids. Mild includes codeine, hydrocodone, tramadol. Strong includes morphine, methadone, hydromorphone, fentanyl, transmucosal or transdermal. But when you start an opioid, I'm not going into the details of drug dosages of opioids. When you start an opioid, it has to be individualized treatment so that the best analgesic effect given to the patient with minimal adverse reaction. And we have to focus on pharmacodynamics and pharmacokinetics of the drug. So thereby we achieve the best performance opioids with minimal dosages. So we have to start with focus on minimal adverse effect and minimal dosages. Therein we can increase the dose of the opioids. So opioids is clearly yes in the treatment of metastasis bone pain. Coming to the anti-osteolytic drugs, as the bone pain in many of the cancers is because of the increased proliferation of or increased activity of the osteoclast, and they cause lytic lesions in the bone. Although there are metastases which are osteoblastic in nature, which causes compression of the nerves and other things, but those cases where osteoclast is the primary culprit or the osteolytic lesions are there, we use, or there is a possibility of osteolytic lesions, we use anti-osteolytic drugs, which includes bisphosphonates, and second is denosumab. So these two drugs basically decrease or inhibit the activity of osteoclasts. Thereby, so bone metastasis is a common source of pain caused by upregulated osteoclastic activity. Bisphosphonates inhibit the osteoclastic activity, whereby the resorption of the bone. And there has been various meta-analysis which have shown the decrease in skeletal related events. Whenever I talk skeletal related events, that means the incidence of fracture, hypercalcemia, spinal cord compression, etc. So this has been found that there is decrease in skeletal related events with the bisphosphonates, and evidence is strongest for breast cancer, prostate cancer, and multiple myeloma. It's a Cochrane review in 2012 which shows there is overall reduction in skeletal related events, which includes pain also, and there is significant improvement in the bone pain after receiving bisphosphonates. So bisphosphonates can be used. Bisphosphonates, when we take, it is concentrated in the newly mineralized bone under the osteoclast, and it modulates the signaling from the osteoblast to osteoclast, and they are beneath the osteoclast. So there is local release whenever there is bone resorption. What they do, they inhibit the osteoclast formation, migration, osteolytic activity, and promote apoptosis. So basically, they inhibit the FPP synthetase, whereby inhibit the differentiation of small signaling proteins in the cell function and survival, thereby inhibiting the survival of the cell and inducing the apoptosis. I'm getting voice of someone. Phosphates can be administered orally. I am focusing more on bisphosphonates and drugs which are not used commonly in other cancers. So bisphosphonates can be administered orally or parenterally, taken empty-stomach, and calcium-rich meals and drinks must be avoided for 30 to 60 minutes, as otherwise chelates may be formed. They are excreted by kidneys, and in cases of improper hydration or dehydration, they may be accumulated in tubules and cause renal injury. So these are the various bisphosphonates which can be used IV or oral. Most commonly we use zoledronate, 4 milligram, 4 weekly doses. Although cloldronate, pamidronate, ibadronate are there. These are the intervals which we have to use. The side effects of the bisphosphonates includes acute phase reactions, which includes the flu-like reactions, gastrointestinal side effects such as abdominal pain, diarrhea, renal toxicity, as I've already explained. It may get deposited in the tubular system of the kidney in cases of dehydrated patients. So it can cause renal toxicity. Osteonecrosis of jaw, as you all know, can occur in mandible or maxilla, which were priorly unaffected by the metastasis. So it must be unaffected from the metastasis to call it osteonecrosis of jaw. It can be in both denosumab and bisphosphonates, osteonecrosis of jaw occurs on prolonged treatment, more than 12 months. If patient is on these two drugs and more than 12 months, it can occur in duration is important. So more than 12 months, they have found the case more than 12 months, osteonecrosis of jaw can occur. Zoledronate is the bisphosphonate with widest spectrum of approval and can be used for reduction of skeletal complication due to bone resection of any tumor entity or multiple myeloma or the treatment of hypercalcemia. So recommendation for the use of bisphosphonates in metastatic bone cancer. When there is acute complications such as acute severe bone pain or hypercalcemia, then intravenous bisphosphonate should be used. They show faster, better effectiveness than oral bisphosphonates. So if there is acute, then we have to use intravenous bisphosphonates. If a long-lasting oral therapy is to be used, then patient should be asymptomatic or oligosymptomatic bone metastasis. There is no scientific evidence that bisphosphonate treatment should be started immediately. There is no, but we or most of the clinicians start after diagnosis of metastatic bone disease and continue for lifetime because resistance against the bisphosphonates is not known. To avoid renal complication, especially with zoledronate or pamidronate, serum creatinine and creatinine clearance to be measured before starting the drug. To reduce the osteonecrosis of jaw, it is recommended that prior dental examination and treatment before the use of bisphosphonates to be done. For patients that require dental procedures during bisphosphonate treatment, a 2-month interruption of infusions is recommended besides antibiotic prophylaxis. Coming to the denosumab. Denosumab is fully human monoclonal antibody which act against the receptor rankle ligand, which is involved in the tumor cell migration and is mediator of osteoclast differentiation and activation. So because of its high affinity and its specificity for rank ligand, it binds with rank ligament and it inhibits rank ligament from activating its only receptor on the surface of the osteoclast, whereby inhibiting the activation of the osteoclast and thereby the bone resorption by the METs. Denosumab 120 mg SC subcutaneously every 4 weeks to be given. Regarding the safety profile of this drug, it is generally well tolerated. Most significant safety concerns with denosumab are osteonecrosis of jaw and infections because it acts on the T cells also. So infection can be there. There is no dose adjustment recommended for renal or hepatic impairment with available data for denosumab. So denosumab is an effective agent for minimizing bone loss associated with cancer treatment, thereby decreasing the pain of the patient. Advantage of convenience with subcutaneous administration, it is not associated with acute phase reactions and renal toxicity. This is a systematic review and meta-analysis, and they found benefit of denosumab over the zoledronic acid related to the skeletal related events in patients with METs, but there is no overall difference in the survival. Increased hypocalcemia and less nephrotoxicity is seen with denosumab. But denosumab is convenient, but it is more expensive than bisphosphonates. So benefit of using these two drugs are reduction in skeletal related events, reduction in pathological fractures, hypocalcemia, reduction in need of surgery or radiation therapy, reduction of the bone pain. Coming to the radiopharmaceuticals. These are radioisotopes which are administered IV and are chemical elements that emit radiation, act on the bone to reduce the effect of the cancer. And it is used when the metastasis is widespread. The most frequently used radioactive isotopes are strontium-89, which is a beta emitter, and samarium-153. Route is intravenous. Regarding the usage of radioisotope, European Association of Nuclear Medicine have given the guideline that the treatment of metastatic bone pain that limits the normal activity, not easily controlled by regular analgesics, or it arises from multiple sites. Radioisotopes are used when the metastasis is in the multiple sites, and it is not controlled by external beam radiotherapy or surgery. So we have to use radioisotopes in these conditions. Although Cancer Care Ontario Program 2004 has given the guidelines that it should be given only in patient exhibiting increased uptake on bone scintigraphy. There is no role in the management of acute spinal cord compression, hypercalcemia, or pathological fractures. So it has to be given with patients of bone mets with pain only, not for skeletal related events. These guidelines report an improvement. It's a Cochrane database systematic review for radioisotopes in metastatic bone pain. And they found that improvement in the bone pain is about 25 to 80% of the patient, and it lasts for 2 to 6 months, and retreatment is possible. So radioisotopes can be used in patients with bone mets, and it can last for 2 to 6 months. Coming to the radiotherapy. Radiotherapy and vertebroplasty, as I've already explained, I already talked about, it is to be used when there are solitary lesions. So radiotherapy comes into the play. The benefits of radiotherapy on the bone pain are mainly related to its capability to produce ossification. Moreover, ionizing radiation inactivates and kills tumor cells. So thereby they decrease the tumor volume and prevent the discomfort and pain of the adjacent nerves. So it has been reported that the symptom relief within 24 hours after initial radiotherapy because of the decrease of the inflammatory cells and chemical pain mediators involved in the pain generation of the meds. So painful uncomplicated bone metastasis if there, then we can have single fraction radiotherapy, which is prescribed, and modality is 3D continuous radiotherapy, and the dose is 8 grade. Although for skeletal related events, there are many doses and many modalities. I am only giving the modality for uncomplicated painful bone metastasis. It is 3D CRT with 8 grade. Dose is 8 grade. Response to therapy, rates of pain relief ranges from 50 to 85%. Up to 1/3 of the patient they report complete pain relief up to 1 year. So response of the therapy is good in cases of solitary lesions treated with radiotherapy. Coming to the toxicity of the radiotherapy, it is predictable and generally self-limiting, as all of us seen in our OPDs. They can be gastrointestinal disturbances, nausea, vomiting, diarrhea, itching, skin reactions, and these toxicities are manageable with conservative measures. Sometimes pain flare is there, where there is temporary increase in bone pain at the treated metastatic site. So anti-inflammatory medications can prevent or minimize the risk of pain flare. By summing these 3-4 therapies, radiotherapy is performed primarily to relieve pain, or definitely control a bone affected from metastasis and prevent pathological fractures and other skeletal related events. Radioisotopes can be administered for more diffuse pain, not eligible for palliative more diffuse pain, and bisphosphonates are considered in case of multiple unpainful skeletal metastasis. Coming to our interventional vertebroplasty. Percutaneous vertebroplasty is minimally invasive procedure guided by fluoroscopy or computed tomography that consists of injection of PMMA cement into the vertebral body. So how this cement acts? There are several hypotheses which attempt to explain this phenomena. First, there is local anesthesia effect. Second, there is stabilization of the fractured vertebra. Third is exothermic reaction on the nerve tissue. And fourth is because of the chemical nature of PMMA, it can decrease the pain of the meds. So there are various contraindications to this therapy, including clinical signs of cord compression, chordicona, fractures of epidural involvement, complete vertebral destruction, posterior arch involvement, and local infection at the puncture site or septicemia. So we have this various study, and they have shown that in osteolytic vertebral fractures and METs, about 78 or 79% of the patient experience good pain relief. And there is another study in which there is 47 patients with vertebral METs compression fractures. The overall rate of patients with pain relief is as high as 88.5%, which is independent of the primary cancer. In case of spinal metastasis, percutaneous vertebroplasty combined with adjuvant radiotherapy seems to be better than radiotherapy alone to relieve the pain and maintain the quality of life and maintaining the posture of the patient. So vertebroplasty is a safe procedure. It has very high efficacy in pain relief. It improves quality of life. Could be performed in patients with poor clinical status. Could be used as first line in cases though there is no immediate availability of radiotherapy, or in which the patient needs fast pain relief just because of the adverse effect and the tolerance to opioids. So it can be used as first line therapy. Complications include, they are basically related to cement leakages, either vascular or non-vascular. Coming to the calcitonin. So there is a study by Dr. Parmanand Jain, P.N. Jain and Aparna Chatterjee, so published in Indian Journal of Palliative Care in 2020, January-March. And it's a randomized controlled trial. It say that injection calcitonin compared to placebo injections, and they have given the injection 800 international unit per day subcutaneously. It's an induction dose and to be followed by 200 international units subcutaneously once a day for 14 days. And they assessed at 14th and 30th day after giving the injection. And they found a significant reduction in pain after subcutaneous calcitonin injection. And it also shows that no patient in the study group required rescue analgesia after 18 hours of administration of the calcitonin. So this is this study published in 2020. But in Cochrane database systematic reviews in 2003, they have concluded that there is limited available evidence and calcitonin may not be useful in controlling the pain arising out of the bone metastasis. So this newer study can be a hope for use of calcitonin in the future, because Cochrane database review has been, it's a date back 2003. So coming to the corticosteroids have moderate analgesic effect in cancer patients. The clinical guidelines recommend the steroids in cancer pain are based on expert opinion rather than an evidence. So moderate dose of dexamethasone 8 mg per day appear to be well tolerated for about 7 days. And there are data show that the analgesic effect on the pain occurs within 5 to 7 days. If there is no observed benefit, then therapy to be suspended in cases of corticosteroids. And these treatment with corticosteroid is to be individualized according to the patient. Coming to the anticonvulsant and antidepressant drugs, wherever there is a neuropathy component, we can use gabapentin, pregabalin, amitriptyline, or any other anticonvulsants and antidepressant drugs. So this is all about controlling pain in bone mets. So if there is a solitary lesions, then vertebroplasty, radiotherapy to be given. If widespread lesion, then radionucleotides can be given along with pain management done by the simple analgesic to opioids. Thank you.
Thank you so much, Dr. Manish sir. An excellent overview of the bone metastasis pain. Now, if Dr. Anurag and Dr. Sarita ma'am is there, can we have the discussion, sir? Anurag sir.
Please go on, Dr.
So there are a few queries in the chat box. I will start with Dr. Sudhakaran first. The initial query is, what kind of syringe do you use for intrathecal neurolysis? Because you are giving 0.1 to 0.6. I guess it's 1 ml disposable syringe.
Yeah, it is a 1 ml disposable syringe is ideal. Hello. It's a 1 ml syringe is ideal because it is easy to give in small increments of 0.1 ml. So ideal is 1 ml syringe.
Okay, another one, if a bottle of an alcohol has been opened, how frequently we can use it?
I think it was answered in the chat box itself. We can reuse, but it is better to take care of immediately, close it immediately.
Okay. And why not alcohol is used in saddle block?
Yeah, the reason being this alcohol is hyperbaric. So when the question you give in relation to the CSF, it will float. And alcohol is a non-selective. It won't differentiate between the sensory fibers or ventral fibers, motor fibers. So if you in the sacral area, it is definitely going to affect both this dorsal roots and the ventral roots, that is motor. So it is not possible to give pain relief without causing motor weakness, which most patients do not want even at end stages. That is the main thing. And there are other options available instead of using alcohol, like we can go for more of peripheral procedures or epidural like that type.
Okay. And another one for you from my side. So which all patients do you select? What is the patient selection? In which patient do you use intrathecal neurolysis? And how often have you done that? Your experience?
Yes. Yes, already told it is only for terminally advanced cancer patients when all other options are void, and it has to be a somatic pain, and the patient life expectancy should be short, and this opioids it is causing more of unwanted side effects like delirium or and these type of things. Then if the patient accepts, like there is no caretakers available to give routine dosage of drugs, then would be a good option. I will go as a last resort, like 1 or 2 months to maximum to 3 months time, if the patient accepts the risks. But as such, I will also counseling them if the risks are very minimal, because I am choosy about my patients. I will choose only patients of cancer, lung, somatic, mostly of intercostal nerve involvement, and anterior chest wall pain, and CA breast. They also have anterior chest wall pain and axillary pain. So mostly these type of patients won't be problematic, because even there won't be much of spread. If you want to cover only 3 to 4 dermatomes, if you give drug at like the T1 to T4 level, mostly it won't go above the mid cervical and not below. So there is virtually very less possibility of causing water paralysis or breathing difficulty. In regarding to that saddle nerve block, it is decided by the time, the prognostic nature of the patient, and possibility of giving sympathetic blockade. First, since it is a more of visceral pain in the pelvic area, so first, if it is a possibility, I will go for this one, the impar block or the superior hypogastric block, whichever is appropriate. Because of the tumor involvement, there is no space or no possibility of intervention to the impar or hypogastric. Then the final resort option would be the saddle block.
Nicely explained, sir. In your slides, there was a patient of 68 years old.
Yeah,
has
yeah.
a big breast mass, and you
yeah.
put the patient in lateral position, then you tilted it for 45 degrees. The reason behind that?
Yeah, because as I told it, we want to then alcohol has to deposit only in the dorsal sensory nerve roots. In tilting that, because it is hyperbaric, this alcohol floats. So we want the dorsal sensory roots to be the highest point, so that the action only at the dorsal sensory roots, not at the ventral roots. Because ventral roots, when it gets bothered, it will cause the motor weakness. So we do not want to have that. So as over the years from the studies, it was known that the 45-degree angulation in the lateral position for alcohol is the best thing to go for to sensory neurolysis.
Okay, sir. Now, thank you so much. Nicely explained, sir. Now, the few questions for Dr. Manish, and the question is, how often Dr. Sudhakaran Kumar has asked this. How often osteonecrosis of jaw has been encountered? Is it more theoretical, or
No,
you
no. As I've already told you, that if the patient is more than 12 months of therapy of bisphosphonate denosumab, then it can happen. Then it can happen. So you have to constantly check whether there is pain, local pain over the mandible or maxilla, or if the patient is on prolonged therapy.
Okay. So we have to have a look over the dentist as well before going to this. Okay. Another question is role of RF ablation for bone metastatic pain.
Uh, there have been studies on RF ablation for bone met pain, although it's a promising area for RF in treating the bone met pain. It's basically done to denervate the nerves of the periosteum. So it can be done, although it's a cumbersome, and it can need actually more studies to be come into the practice. So RF ablation can be done. And alcohol and phenol we have not used, and I have not searched literature regarding alcohol and phenol.
For solitary metastasis.
But for MR guided focus ultrasonic beam therapy, and it's a promising actually therapy for bone pain meds, solitary meds. It basically work on the principle of thermal ablation of the meds or the localized region. So it can be done. But there are some contraindication to this therapy, such as if there is already a irradiation over the skin is there, or the fracture is, if the bone is very fragile. So these are the 2 or 3 contraindications for this MR guided focus ultrasonic beam therapy, although it can be done. So these RF ablation and MR guided focus ultrasonic beam therapy to be included in the management of the bone.
And do you have...
May I say a few words about the radio frequency ablation thing?
Please, Dr. Narendra.
Anurag.
Dr. Anurag.
So, basically, it has been promoted and propagated for the solitary metastasis in the axial as well as peripheral skeleton. The aim there is actually twofold. One is to create a room for the cement, which is usually followed later on after the radio frequency. Secondly, radio frequency also ablates the tissue and nerves and nociceptive elements, as rightly mentioned by Dr. Manish. So there are two things which are the aim. The problem with this, with us pain physicians for using this modality is that it requires a larger size of radio frequency probe, which has been made and propagated in West by a few companies. But that probe is usually not available with us. Our radio frequency needles of cannulas are at the most of 18 gauge. So that is quite thin. So there are few probes available in the West now in our country also. So if you have got them, they are very good to use because what happens when you try to put cement in these lesions, many times they are not of osteolytic by nature, rather they are mixed, or sometimes even they are osteoblastic. So it becomes difficult to push the cement percutaneously in these lesions, which otherwise gives very good results if you are able to do it safely, as Dr. Manish has already mentioned. So radio frequency gives you a room if you are able to ablate some of the tissue. It treats the lesion also, and it makes the success of your cementoplasty more useful. So it has got certainly a role. There is not much role of denervating the structure itself. This is what I have understood by my experience as well as the literature. Because if there are multiple level mats or they are even at a single level mat, so it is difficult to denervate that single vertebra or that part of ileum by using the radio frequency. So aim there is to local ablation of tissue, metastatic tissue, and to create the room. So this is my take on the radio frequency.
But RF works mainly on theoretical. It's a theoretical view. It works on the basically nerve destruction of the periosteum involved in the metastatic process.
Maybe with the larger probe, which is specifically designed for this thing, because that will create the big lesion. So it may reach up to the periosteum also. Otherwise, with our needles, which we have, you can try to make multiple lesions in different directions if you are using a curved needle, and that may give you some place to put your cement in. So this is my take on. Amitesh, you can continue.
Thank you so much, sir, for your advices. That was the last query, I guess, in the chat box. If Sarita ma'am or Anurag sir has any query.
Dr. Sarita?
Conclude the session.
Hello.
Hello.
Amitesh, conclude कर दीजिए.
Amitesh?
Ma'am, it's up to you, ma'am. There are no more queries in the chat box. If someone has, we'll wait for 5 more minutes. If someone has any query or any doubt, they can put it in the chat box.
Amitesh, what I want to emphasize in my presentation that we have to rely on radioisotopes and radiotherapy for isolated and widespread lesions. So कहीं ना कहीं हम लोग कम यूज करते हैं एक्चुअली पेशेंट्स को भी कम मुझे लगता है कि रेफरेंस होता है फॉर रेडियोथेरेपी और रेडियो आइसोटोप्स के लिए समैरियम एंड एस्ट्रोनशियम के लिए.
Okay. But majority
And we are less using denosumab actually.
So your experience with denosumab?
No, I have used only in one patient. So because of the expensive nature of the denosumab, that's why bone metastasis is many a times difficult to control. And the patient come in OPD कि सर आराम नहीं मिल रहा है. आप अगर जो स्टडी में आप देख रहे हो कि पैरासिटामोल और NSAIDs के लिए थोड़ा सा लिमिटेड रोल है in cases of bone mets and other cancers. So ये emphasis था.
Actually, what if I would like to share my own personal experience, just for the sake of sharing, because we haven't got it published or have any evidence. So this is just the anecdotal evidence. For the bone metastasis, we start that with the NSAID by the oral therapy, but of course, and most of these patients do come to us either from the radiation oncology, that is radiotherapy, or from the medical oncology. So if they are coming from the radiation oncology, and in any case, unfortunately, we pain physicians are still at the last step of the ladder. When they exhaust all the options, including the radioisotopes as well as the radiotherapy, only they come to us of calcitonin. So that usually gives good relief to our patient. Then we try to find if whether we are able to do the cementoplasty in these patients safely. So unfortunately, most of the time, I can say that 8 out of 10 times, patients are having multiple mets in their spine or their long bones or their sacrum ilium. But by the time they reach to us, they are already breached the periosteum and in the soft tissue component, with the soft tissue component. Then it becomes cementoplasty becomes tricky as well as dangerous to the patient, because as the first principle of the medicine, that do cause no harm. On the basis of that, we are unable to employ cementoplasty, which is our forte as a pain physician, to employ with most of these patients. But having said that, in the patients in which we have been able to do the cementoplasty, be it in the sacrum, be it in the ilium, be it in the other bones of the vertebral canal, spinal canal, and few of the long bones also, they have got remarkable and wonderful pain relief and lasting pain relief, and without any side effect, because if the peri-procedure, peri-intervention period is uneventful, then there is nothing which can be a later complication of our interventions in these patients. So that is something amazing to do and practice. So certainly patients should get all the options in their hand But as a pain physician, I would like all of us to use cementoplasty more and more often. It is quite simple, a procedure, a one-time procedure, and with the remarkable pain relief. It is still not in much of the literature because there is almost no RCT available. Many people are trying to do that in collaboration with other specialties. Let's see when it will happen.
No, I have quoted those two cities, and they have shown that 80 to 89% of patients are getting pain relief.
Oh, sorry, I missed that
so,
slide.
But there is good evidence for this vertebroplasty for solitary
Not
patients.
only vertebroplasty, I am talking about the cementoplasty. Vertebroplasty, when you do it in sacrum, you call it sacroplasty. When you do it in the ischium, you call it ischioplasty. So whatever, I mean to say that cement is something which gives wonderful results if we can do it with our patients safely. If the peri-procedure period is uneventful, be assured that patient is going to have good relief without any late complications. So this is my 2 words. So Sarita ma'am, please.
Experience with calcitonin. Calcitonin, would anyone would like to share their experience with calcitonin?
Yes, I am telling you now. We always give calcitonin nasal spray because that is more patient friendly. Patient need not be pricked for it. And for the metastatic pain, we use it in the BD doses. For osteoporotic patients, we use it in OD doses usually for the bone pain, generalized bone pain. But for metastatic pain, we use it BD, and that usually gives good results. Along with all other medicines. I'm not saying that all other medicines are not to be given. Denosumab is a wonderful drug, especially for the osteoporosis postmenopausal. I am using it very frequently. But for the metastatic pain, again, because of the cost constraints, I haven't used it. Because again, reason is that I am getting good relief with the cheaper medicines. And these patients are usually, which we get, are very poor. They have spent almost a fortune on their treatment of the primary disease. So, but there are few trials are going on. I am aware of that. And again, there is one more thing I would like to say about the cementoplasty in versus the radiation therapy. So radiation therapy, as per the literature, is the primary therapy for the bone metastatic pain and bone metastasis treatment. But at the same time, literature also says that radiotherapy is effective only in 50% of patients, that too after a time lag of around 4 to 6 weeks. So it is not that only one therapy, only one size fits all. So you have to tailor and custom your treatment.
You have to individualize the treatment.
Individualize the treatment. That is, I think, the crux of the.
So regarding calcitonin, there is in our society there is stigma about subcutaneous injections. So it is better to give oral or nasal doses rather than subcutaneous. So patient take it easily if nasal or oral doses are given rather than subcutaneous or injectable doses.
Yes. So injections are never preferable.
Just like insulin की insulin लेते हैं तो फिर वो दिक्कत वैसे they can take long time OHA rather than insulin.
Dr. Manish, what a shorter regime like we do for calcitonin, we used to do it as a shorter regime for maybe 10 days given daily and then alternate days for a month or so. So what about that? Like because it used to have a good effect, especially in osteoporosis. I don't know about, I do not have any experience with cancer patients, but in osteoporosis it used to do wonders. Like
in osteoporosis, we are using for long term actually in lower doses of 20. But
what I mean to say is parenteral using the parenteral route for a month or so and then shifting to nasal, because the nasal would take time otherwise. It would be a slow action. It would there won't be something we can't expect very drastic results very quickly. But like what I mean to say is you have told one regime done by Dr. Jain and all. Is there any other regime of using
scarcity of actually literature regarding calcitonin use in bone mets with significant results actually. So this I have got from Dr. P.N. Jain, which he uses 800 international unit loading dose, then 200 every day for 14 days. And they have this extrapolated the result for 14th and 30th days of the treatment. So what frequency it has to be used? I will check it
But I
out.
mean to say, yeah.
No, actually, the
Because
problem
it's
with
a
all
shorter
these
regime,
drugs
like
like
2 weeks.
calcitonin as well as
It's a
denosumab.
2-week therapy actually. They have tested for
Yeah.
2 weeks.
So that is a problem because
Because
all
see,
these denosumab as well as calcitonin in the bone metastatic pain, they are using it in very high doses. The recommendation is very high doses. So again, that causes a cost constraint, especially with the denosumab thing. So it is an open field for everybody. And this statement Dr. Pushpinder is saying is that this protocol has been devised by Dr. Rastogi sir. We all have used it, and it has
yeah,
certainly worked very well with our osteoporotic patients, especially in the postmenopausal period.
yeah,
But for the bone metastasis, and currently speaking frankly, this is not my drug of choice. As per the literature, I am going for the either for the teriparatide or for the denosumab, even for the osteoporotic patients with a very good results, which are actually objectively proven by the BMD DEXA scan improvement. So again,
teriparatide is definitely, Dr. Anurag, teriparatide is definitely okay. But then what I would say is that using calcitonin in a parenteral this thing compared to, because I don't think there is an issue with the bioavailability using it with a nasal spray route.
mhm,
So, and secondly, they say that even with a nasal spray, it shouldn't be used for that long.
mhm.
It should not be used for that long, even with the nasal spray route. And secondly, its effect is not as much what is there with the parenteral this thing.
Yes,
So that's why I'm saying that maybe,
yes. It can be
yeah,
tried. No harm in that. Or actually, duration for long duration is not a problem with the unfortunately with the malignant patients. They, in any case, when they come to us, they have a very limited life expectancy. So, but
limited
your
life.
point
Okay.
is well taken. In that scenario, we perhaps can use with the parental route in some of our patients and see the response if there is any difference. So certainly, it is a good point.
Yeah. Maybe.
Even we have used in patients of meds, but with a lower dosage of calcitonin because of
Yeah.
the cost
Yeah.
constraint and our usual
Because
prescribing the
what I
medications
mean
in
to say is 800
osteoporosis
units.
patients.
It,
Yes.
yeah. Because 800 units loading dose is quite much actually. I was just thinking, I was just wondering that maybe like if we can maybe do away 100 units given daily and all for 2 weeks and all is okay. Maintenance is all right, but 800 units, if they have, there might be some logic of giving it. But what 800 units giving, because what you told about Dr. Jain, how they are giving. So I was just asking that any other thing, any other regime, and if they have any better effect or if not. So what I mean of using calcitonin, parenteral calcitonin, subcutaneous, sorry.
Earlier studies or systematic reviews have given no evidence for using the calcitonin in bone pain. Actually, might be because of
Yeah.
some results. But this is promising study
Yeah.
I have found and I put it here. So still more studies to
Yeah.
be done regarding the regime of the calcitonin in bone meds patients.
Okay.
That is
Thank you.
today's takeaway.
Huh.
Dr. Ajit is there?
Avas.
Huh. Dr. Ajit, I would like your presentation was also very good and very new something it had that about the inferior hypogastric plexus MIPSI or rhizolysis. So, what is your preferred way of doing it, and what are the patients you are
Lateral
using it?
approach.
Lateral approach,
Hmm.
and
First location of piriformic muscle and then
okay, you are going through the piriformis.
piriformic.
That is actually a new idea. So, and what are the results like?
बस हम लोग तो जब ट्राई किए थे तो 2 में फेल हुआ था, 3rd में सक्सेसफुल.
Okay, okay,
दिस इज द रियल.
okay. So,
मेन
are you
का जो
using
भी
the?
स्लाइड था वो सारे चीज लॉक हो चुका है कोरोना के चलते. ओपीडी ब्लॉक पूरा सीज हो चुका है, इसीलिए हम लोग उसका स्लाइड हम नहीं दिखाए.
Video.
आया था एक तो पायरिफॉर्मिक सिंड्रोम आया था, तो उसका भी हम लोग लगाए थे, लेकिन 3rd केस में सक्सेसफुल था. उसमें 70%.
Okay.
But sorry, Dr. Ajit, but what was the indication of you are using inferior hypogastric for like same indications as superior
Generally
hypoglycemia or for any?
rectum and perineal pain के लिए मैं most indication है rectum and perineal.
Okay, and you did a neurolysis, मतलब with alcohol or something.
No, neural first diagnostic block. If 100% successful, then others neurolysis RF you cannot do. RF is their contraindication because chances of rectal perforation is not.
Sir, is there any consensus behind whether using 50% alcohol, 70%, someone uses 100%, someone uses 50%, someone uses 70%? इसका कुछ है क्या?
अभी एक स्टडी हम लोग कर रहे थे और हमने एक थीसिस भी कंप्लीट करी है. उसके जो हम कर रहे थे हमने देखा कि literature says that whether you use 50%, 75%, it does not make a much difference. Above 50% is okay.
Okay.
And others views are warranted.
Hello.
डॉक्टर अजीत
जी मैडम.
कभी इंफीरियर हाइपोगैस्ट्रिक के साथ आपने गैंग्लियन इंफार का भी प्रैक्टिस किया है?
गैंग्लियन इंफार हम लोग से ट्राई किए नहीं है मैडम. उससे मेन है कि हम लोग ट्राई सी आर्म से किए थे और सी आर्म से हम लोग का हुआ भी है, लेकिन हम लोग अल्ट्रासाउंड गाइडेड ट्राई नहीं किया.
अच्छा.
डॉक्टर मनीष. हेलो
जी बताइए.
What is the biological role, especially in osteoclastic and osteoblastic activity? What is the role of pain? Biological role. Metastatic pain. There is any role of
biologics,
such as modification of activity of osteoclastic and
these two drugs actually, bisphosphonates and denosumab, they are
other biological, not.
No, they are not actually studied.
Study में इसका biological role, especially हम लोग इधर recently one medical oncologist has been this type biological role of especially bone pain, such as modification of activity of osteoclastic activity, such as mutation of certain given intracytoplasmic activity.
No, which drugs actually?
ड्रग ने वो काइमेरिक एक्टिविटी भी कराते हैं. ड्रग बहुत सारा चीज उतना याद हमको नहीं आ रहा है.
ओके.
बिग टॉपिक बायोलॉजिकल रोल ऑफ बोन पेन.
नहीं, these two drugs they acts on actually osteoclasts and they induce the apoptosis.
They are not drug, just antibody and osteoclast.
No, so denosumab is actually monoclonal antibody actually.
Yes, लेकिन there is modification of antibody and then chimeric to the osteoclast.
Okay.
Intracellular activity. वो बता रहे थे, उतना डिटेल में नहीं देखे. Just
all the therapies are just to induce the apoptosis. Induce the apoptosis of these osteoclasts, so as to decrease the osteolytic activity.
Just to modify the osteoclastic activity.
Yeah.
Okay.
And Dr. Manish, one question, like among the bisphosphonates, like is there any preference, like which bisphosphonates do better, the weekly this thing, or they give that zoledronic acid once in a year, like
in bone meds? For IV therapies, chloride is preferred, and for oral therapy, zoledronic acid is preferred. Although we use, or most of the studies are using zoledronate as primary bisphosphonates, although chloride IV to be used if it is available.
I'm sorry, which one?
Chloride.
Zoledronic acid will be used.
Zoledronic acid IV and oral can be used in India because India zoledronic acids काफी available है. But chloride जो primary जो था हमारा bisphosphonates वो भी IV यूज करते हैं. उसके अच्छे रिजल्ट्स.
But उसकी frequency क्या होती है?
उसकी frequency
What is the frequency?
I have to go for the slide actually.
For zoledronic acid for bone metastasis.
4 weeks.
वो तो annually.
No, not
Zoledronic acid. तो
4 weekly. 4 weekly. No. It's 4 weekly for med pain and annually for osteoporosis.
Okay. और what I mean to say is कि अगर suppose if there is no जैसे आपने कहा कि कोई acute ऐसा पेन नहीं है, so efficacy दोनों की बराबर है क्या कि giving, because many times what I see is that they prefer giving the zoledronic acid की कुछ भी है, चाहे acute है जो भी है, कि वो zoledronic acid तो दे ही देते हैं कि भाई दे दिया. What I mean to say is कि जो हम जैसे जो weekly या जैसे orally देते हैं, तो दोनों की efficacy में क्या फर्क है? Is it that zoledronic acid given IV has better efficacy than the weekly this thing? मतलब is there any comparison among the bisphosphonates which is better?
IV को जैसे I've told कि IV to be used when there is a acute incidence of pain. Okay. If you have to go for a maintenance therapy or asymptomatic or oligo involvement is there, then we can use zoledronate, and there are no evidences कि it has not to be used when there is no symptoms. So zoledronic acid can be used even if the bone meds doesn't causes pain in patient with meds.
और ओरल में हम कोई भी यूज कर सकते हैं. ओरल में इनमें एफिकेसी में कोई फर्क है? लाइक ओरल में जैसे जो
ओरल में
बाकी जो
आप जोलेड्रोनेट एंड पैमिड्रोनेट आप यूज कर सकते हैं.
Zoledronic acid comes in the oral preparation?
नहीं, रेसिड्रोनेट. नहीं,
Zoledronic acid I don't think it comes in the oral preparation.
नहीं, ibandronate and this pamidronate.
There are so many aldronate, abandronate, there are so many other preparations, but not zoledronic acid.
Zoledronate in IV.
Zoledronic acid is only available in the IV, and the dosing is yearly for the postmenopausal osteoporosis and monthly for the bone metastasis.
It is monthly for bone metastasis,
and it's very commonly used drug. So, and everybody is using it by all the oncophysician, oncologists, oncosurgeons.
Ibandronate and chlorodronate oral are available.
Yes.
मनीष, जो आप ये ओरल बता रहे हो, आप बता रहे हो कि पेन से पहले इसको दिया जा सकता है, तो इट इज प्रोफाइलैक्टिक, मतलब
ओरल कोई एविडेंसेस नहीं है कि आप नहीं शुरू करें या शुरू करें, बट आप शुरू कर सकते हैं
विदाउट पेन.
हाँ, विदाउट पेन एसिम्प्टोमेटिक पेशेंट्स में भी शुरू कर सकते हैं, बिकॉज उसका रीजन है कि दे गेट डिपॉजिटेड इन जहाँ पे भी ऑस्टियोजेनेसिस हो रहा है और जब भी ऑस्टियोक्लास्टिक एक्टिविटी स्टार्ट होती है, दे रिलीज फ्रॉम देयर एंड डिक्रीज द एक्टिविटी ऑफ द ऑस्टियोक्लास्ट. सो दैट कैन बी गिवन इन एसिम्प्टोमेटिक मेड्स पेशेंट्स.
And maybe fracture prevention can be a role, if not pain.
ठीक है.
Hello.
मैं कहा दूसरा role can be in reducing the chances of fractures and acute events, right?
Yes.
Apart from pain, all the skeletal related events such as hypercalcemia can be treated or can be controlled with these drugs.
एक्चुअली एक कॉम्प्लिकेशन मैंने फेस किया अभी बोन मेड्स के पेशेंट में, जो यहाँ शेयर करना चाहती हूँ फॉर डिस्कशन. I saw a patient of CA prostate with bone meds in spine, and ये नहीं पता चला कि meds उसको ब्रेन में भी हैं. So I have given NSAID plus tramadol 50 milligram PD, and patient has got convulsion. So क्या और करना चाहिए था इसमें? Because tramadol causes the decrease the threshold for the convulsion. So pain भी बहुत ज़्यादा नहीं था. That's why I added tramadol plus NSAIDs.
ट्रामाडोल का EEG पर कोई फर्क नहीं पड़ता मैडम, उसके थ्रेशोल्ड पर कोई फर्क नहीं. There is no role of tramadol, especially threshold of the low threshold नहीं करता. There is other factor related to convulsion.
Okay.
ट्रामाडोल बंद करके मैं एंटी कन्वल्सेंट स्टार्ट कर देता.
हाँ, फिर यही हुआ.
So I think all questions are over. Amitesh, is there any other question?
Yes, I guess all the questions are over. And thank you so much all the esteemed speakers. It has been an excellent session. Throughout all the three headings and the speakers have been phenomenal. Now it's over to Anurag sir and Sarita ma'am to finish off this session.
So to Dr. Anurag.
So I would like to thank all the speakers, Dr. Manish Singh, Dr. Sudhakaran, Dr. Ajit Kumar, for their wonderful presentation in this educational initiative of Indian Society of Pain Clinicians. There was a very good stimulating discussion afterwards. I thank to all the participants as well as all the audience, Dr. Sarita Singh, and thanks dear Amitesh for amazing conduct of the program. And with these words, I take a permission to end this meeting. And good luck and take care of yourself.
Thank you. Bye-bye.
Thank you.
Thank you. Bye.
Bye.
Thank you.